Hi, good afternoon, everyone. Thank you for joining us for advanced echo teaching in the critical care for today. We're going to talk about heart-lung interactions, and then I'll present a case at the end. This is fairly key to, critical care ultrasound. It's a very commonly topic that's taught, and I generally find when I'm arranging echo conferences, the person who I like the least or the person who's the smartest in the faculty always gets this lecture. I never ever do it myself because it's really, really hard. So forgive me if I get things wrong in it. I still struggle to try and remember everything. I'll tell you my really simplistic view, and then I'll take you through some amazing slides written by Andrew Hilton. So for those of you who don't know Andrew Hilton, he's a senior intensivist in Australia. He's the censor of the college. He's got to be one of the smartest people I've ever met. So he always gets this and diastolic dysfunction, you always give to the smart people. So a lot of the stuff from here I've stolen from his lectures. So please interrupt me if you think I'm talking rubbish. We'll get through it together, and it is worth knowing for the exams, at least the simplified version that I'll teach you. Okay, let's start off with nice and simple. So positive pressure ventilation can cause which of the following effects on the heart? Can it increase your LV preload? Can it increase your RV preload? Can it increase your RV afterload? Can it cause the interventricular septum to bow to the right? Or can it cause lung underinflation and hyperventilation both reduce pulmonary vascular resistance? We've got someone calling in. 3, that is correct. Ben, as our local respiratory expert, can you tell me this?
I can. I'm a bit distracted because I'm sitting in the Blue Mountains at the moment. So my thoughts tomorrow than on today.
So Ben is running 100 kilometers tomorrow, which is slightly insane. So good luck.
Okay, I've had it checked. So positive pressure ventilation increases intrathoracic pressure.
Yeah.
So reduces filling from the IVC and from the SVC. So you get reduced RV filling. It can also cause increased RV afterload.
Fantastic. So that's why 3 is the right answer.
Because by inflating the lungs, you're...
Nice. And the interventricular septum, if you increase up the pressure on the right side of the heart, is going to be bowed to the left, not the right.
Yeah.
And what about the last bit with the pulmonary vascular resistance? Lung under...
Missed that. No.
So what happens? Why is number 5 wrong?
Because it won't reduce pulmonary vascular resistance. You're increasing the air pressure in the alveoli, which will collapse the small vessels.
And if you hyperinventilate an alveolus, it will squish the pulmonary vasculature and increase pulmonary vascular resistance. Yeah. If you have areas of the lung which are underinflated, you're going to cause, you won't get oxygen and carbon dioxide being transferred, so you'll get localized pulmonary vasoconstriction.
Yeah.
So you increase your pulmonary vascular resistance in both of those.
End stage COPD.
Nice, yeah. Cool, excellent, well done, nice place to start. Okay. So with positive pressure ventilation, and we'll come onto spontaneous ventilation in a sec, because I find it's easiest to start with positive pressure ventilation. So positive pressure ventilation, the bog standard thing I try and remember is that you're going to get a rise in lung volumes. So as you get a rise in lung volumes, you've got an enclosed space, so you will increase your mean airway pressures. That is going to cause changes in your pleural pressure to be raised as well. And the pleural pressures and the increased lung volumes will all cause the diaphragm to be squished down, which will increase your intra-abdominal pressures. And so obviously that's just a simplistic place to start. What that will do in terms of the actual pressures in the heart is going to be a little bit dependent on what the compliance issues are in the lungs and the resistance and the compliance issues. But taking that as an aside, the way I think about it is that if you've got the pressure inside your chest here, and there's the pressure inside your abdomen. If I put you on I'm going to think about each chamber in turn, starting with the right atrium, then going to the right ventricle, left atrium, left ventricle. So if we've got pressure inside the chest that's here, and the pressure inside the abdomen is there, you have to have a lower pressure in the abdomen because you need that pressure difference for blood to flow into the right atrium. Yeah? So maybe I should have it the other way around. Maybe that's better. So maybe that's the pressure in the abdomen, and you've got to have a lower pressure in the ventricle because you've got to have a pressure difference for flow to happen. If you stick someone on positive pressure ventilation, you increase that pressure in the right atrium. That squishes the diaphragm, which increases the pressure in the abdomen, but to a much lesser extent than what happened in the chest. So it's that difference between those two values, which is the pressure difference, which is flow, right? So if it started off like, sorry, I got a couple in the thing. If it started off like that, I then do positive pressure ventilation. It goes like that. The difference is less. So that means that you will reduce your RV preload. All right. It's also going to affect the RV afterload because as you increase pressures in the chest, you're going to make it harder. You're going to squish the blood vessels in the pulmonary vasculature, which means the RV is going to have a harder time trying to get blood into the vasculature. So you're going to have increased RV afterload, just like Sam and Ben just said. If that all happens, that means you're going to have less blood going around and round and round, which means that you're going to have less blood going into the left atrium. So you're going to reduce the left atrial preload. And then the last thing is about afterload, which I always found quite hard to get my head around. So again, using these pressure differences. So afterload is defined as the pressure difference between the left ventricle and the pleural space. So the pressure difference across the ventricle wall, basically, times by the radius divided by the wall thickness. But the main difference thing is the thing on the numerator, the top line of the equation, is the pressure difference across the ventricle wall. So again, you've got the pressure inside the ventricle and you've got the pressure outside the ventricle in the pleural space. If we increase up pressure in the chest, that pleural pressure is obviously just your thin pleura. That's going to go up quite a lot. Whereas because you've got a thick ventricle wall, it's going to make that pressure go up a little bit, but only just by a small amount. And again, it's that difference between those two values that is afterload. So if it starts off like that, and then we put on a positive pressure ventilation, that goes up quite a lot, that goes up a little bit. Again, the difference is less. So that means that we have got reduced left ventricle afterload. So reduced RV preload, increased RV afterload, reduced LA preload, decreased LV afterload. Yep. If we reduce the LV afterload, it makes it easier for the heart to push out blood, obviously. So what it all comes down to, what this effect is going to cause on the hemodynamics, is going to be dependent on the underlying physiology. And again, my simplistic understanding of that is if I've got Lewis here and I sedate him, paralyze him, and mechanically ventilate him, he's got a normal heart because he's running 50 Ks tomorrow. So he's got a normal heart. And that means a normal heart is preload dependent. As in, with all of us who hopefully got normal hearts, if you give us fluid, you will increase our cardiac output. That does not, just because we're fluid responsive, doesn't mean that we're hypovolemic. You know, we don't need the fluid because we're not in shock. Okay, so again, that's another talk on fluid responsiveness. But we are all fluid responsive in our normal states because we are preload dependent. As in, if I give you a whole bunch more preload, you will increase your cardiac output. Now, Mrs. Smith, who is 90 years old with her ischemic cardiomyopathy, diastolic dysfunction, and a bit of hypertrophy, who's in APO because she's had a little non-STEMI, she is afterload dependent. So both Lewis and Mrs. Smith are going to have the same responses that we've just discussed to their physiology. But Mrs. Smith is afterload dependent, and therefore, when I've ventilated and intubated Lewis, his blood pressure goes up or his cardiac output goes up. With Mrs. Smith, we actually reduce her physiology. We actually improve, sorry, let me say, Lewis, with his preload dependent, when I ventilate him, he is fluid responsive. If he's preload dependent, I reduce his preload, his blood pressure goes down a little bit. Excuse me. Mrs. Smith is afterload dependent. I reduce her LV afterload, therefore her blood pressure actually gets better or goes up because she is afterload dependent, and that is all based that her heart then becomes more efficient. And that's why Mrs. Smith loves non-invasive ventilation when they're an APO, okay? So it's got nothing to do with forcing fluid out of the lungs. It's got everything to do with reducing LV afterload, making her heart work more efficiently. I think I explained that rather badly, but I hope you get the idea behind that. Does that make sense?
Yeah, the second time.
The second time, yeah. The first time was rubbish. The second time's better. Yeah, so preload dependent, your preload falls, your stroke volume falls. If you're afterload dependent, your stroke volume increases because your LV afterload decreases. Oof. Right. Now I'm going to try and explain that with Andrew's slides a bit later. So this is important because we're going to talk about a few different things, mainly LV failure with weaning from mechanical ventilation, because that's when it's going to be most important. Okay. It's also going to be important to think about it with hypovolemia. All right, next question. Lewis, I'm going to show you which of these following patients would most likely benefit from being extubated to non-invasive ventilation. So tell me what you see in each of these. I think I'm going to play them in turn.
Okay, so clip A is a apical 4 chamber.
Yeah, apical 4, yeah.
Probably moderate to severely reduced ejection fraction with what looks like to be a large left atrium. So there's going to be systolic and diastolic dysfunction. And so that patient will very likely benefit from it being extubated to non-invasive.
Nice. Because why are they going to benefit from being extubated non-invasive ventilation for the crowd?
So for exactly the reasons that you just explained, high diastolic dysfunction, high filling pressures,
yeah,
improvement in LV afterload, improvement of LV systolic function as a result.
Nice. So it's like a staged extubation. Very nice. Does it mean that this person is going to survive extubation? Well, of course not, but it's a way of trying to at least stage it so they're a bit better. So absolutely, someone with LV systolic dysfunction by definition has LV diastolic dysfunction. By definition can very easily have a raised left ventricle end diastolic pressure. We need to make sure this patient in A is pretty close to being hypovolemic almost, so that we don't, because we're going to increase up his left ventricle end diastolic pressure as soon as we extubate him. So we're going to do a staged approach to try and make sure he's okay. What about B? B, what do you think about that?
Me again. So
yeah, you might as well go
it's apical 4 chamber as well. The most obvious abnormality is the size of the right ventricle and the right atrium.
Yeah.
There's enlarged right ventricle. It looks like there's poor longitudinal and radial function, so reduced systolic function. Right atrium's enlarged and the interatrial septum pushing over to the left, so there's high right atrial pressures.
High right atrial pressures.
And probably RV dysfunction already, so they will benefit being off positive pressure ventilation.
Beautiful. So they'll benefit being off positive pressure ventilation because they've got raised right atrial pressures and an RV that looks a little bit problematic.
Me again?
Yeah.
Okay. So
that's meant to be normal.
Is it?
Yeah.
There's quite a pronounced moderator band, and that RV wall looks a bit thick.
I think I chose a bad example.
Right,
that was meant to be
a bit big.
That was meant to be normal. Yeah, okay, I chose a bad example.
Maybe normal for athlete.
Yeah, nice. I was looking for someone who had a bit of an interatrial wiggle between the two atria, suggesting probably left atrial pressure wasn't raised. And with relatively normal LV systolic function, but I think I chose a bad example. But you get the idea. If you've got an interatrial septum that's wiggling around with atria that don't look horrifically dilated, normal LV systolic function, you're probably going to be okay with your left ventricle end diastolic pressures. And then this last one that again hasn't come out very well is someone with some systolic anterior motion of their interventricular septum, and they're significantly, because of significantly hypovolemic. All right, and again, I don't think you need to put someone who's hypovolemic onto non-invasive. You just probably need to get them off the ventilator and see where the hemodynamics are. Nice. All right, so let's just quickly talk about weaning, just like Lewis talked about. So the weaning effects we talked about are about trying, because when we take a patient off mechanical ventilation, we're going to reduce their intrathoracic pressure, which means that for all of those reasons with the left ventricle ventricular pressure difference between inside and outside of the ventricle, we will increase their LV afterload because we will have increased their transmural pressure. All right. So that means that we can therefore cause an increase in the LV end diastolic pressure. We can impair that LV compliance because of that, which means that we can increase the left atrial pressure, which means that we can push them into pulmonary edema. So hence, we want to try and look for signs of raised left atrial pressure before we extubate someone. And again, that's probably a talk into itself about how we do that. Bog standard thing that I'll use is an E to E prime of at least 15. All right, that is not perfect. So I'm also going to look at the left atrial size, the interatrial septum, the E to A ratio, and I guess probably most importantly, particularly because we got Kylie on the link here, is talking about lung ultrasound. All right. So I think lung ultrasound is really, really useful when we're talking about taking patients off ventilators, looking for increased interstitial fluid. Again, a little plea about lung ultrasound. Just because you've got B lines doesn't mean you've got raised left atrial pressure. There are lots and lots of reasons for B lines, not least a pneumonitis. But one of those causes can, of course, be fluid that we drown our patients in often. Okay. Mechanical ventilation versus RV afterload. So the alveolus are not homogeneous throughout the lung, of course. If we've got a patient who's standing up, you know, the pressure around the basal alveoli will cause potentially some atelectasis, and if they're being ventilated sitting up, their basal alveoli can be more atelectatic, if that's a word, versus their apical ones that are going to have improved compliance because they don't have the mediastinum sort of squishing down on them. And I think if they're lying down flat instead of base, I could just have posterior versus anterior. As we ventilate someone and we put them onto positive pressure ventilation, we move a lot of those alveolus up the compliance curve of volume over pressure. And hence, depending on what your pressures are inside your heart, we can over-distend some, we can get it perfect with others, we might not overinflate enough. And that's why I think that mechanical ventilation needs to be individualized to individual patients. All right? That can, of course, though, some of these problems, both with overinflation and underinflation, can affect your right ventricle. So even in normal hearts, so these are normal pig hearts that I bullied. So in normal pig hearts, we have the ability to dilate up their right heart with ridiculous mechanical ventilation if they're sedated and ventilated on the by a vet, right? So I took 10 pigs. I did intracardiac echo, so it's a bit weird, but just look at the right ventricle here. So this is the right ventricle, which has got speckle tracking on, and there's the left ventricle there. Don't worry about the speckle tracking. Just look at the size of, look at the way that right ventricle free wall is moving. And when we put them on ridiculous levels of PEEP, we caused that RV to expand, and we called it to be dysfunctional. And that's because we're increasing up the RV afterload. So I hyperexpand that alveolus, you squish the pulmonary vasculature, increase RV afterload, all right? The same kind of thing can happen if you've got a alveolus or a lung that's full of pus, blood, rib fractures causing atelectasis, pneumothorax, I don't know, anything else. So if you start squishing down an area of the lung, we get reflex pulmonary vasoconstriction, which causes blood to be redirected to areas of the lung that are not blocked up for whatever reason. And the way that it does that is anything with reduced oxygen tension, increased carbon dioxide, or acidosis causes reflex pulmonary vasoconstriction to redirect blood to an area of the lung which can actually work. So what do I take away from that? Well, I think heart-lung interactions are particularly important because we want to make sure that we do not have lungs that are atelectatic. Again, I don't know whether that's a word, but I'm making it one. so that if you've got really low lung volumes and they're filled up with pus, just squished down for whatever reason, you will increase your pulmonary vascular resistance because of pulmonary vasoconstriction. At the other end of the spectrum, if we have overinflated the alveolus, so you've got ridiculous lung volumes, you will also squash those blood vessels there, and that just increases your RV afterload for that reason. All right. So optimal PEEP and mean airway pressure, again, I think is open for debate. And that's why I think we should individualize the different patients. You got to see what their compliance does, see what their saturations are doing, see what their hemodynamics are doing, and see what their right heart's doing. Because if you over-distend them, you will dilate up that right heart, squish that left ventricle over, and potentially cause congestion from right ventricle failure. Going to slick away. All right, let's do something interesting. Okay, here we go. Sid or Kylie, do you want to have a look at this patient? So Sid, I've got a 40-year-old asthmatic who's been intubated many times before. They're from Penrith, so they don't want to stop smoking. And even despite being intubated several times, comes into ED on a Monday, breathless, flu A positive, gets intubated. We've got them on an anaconda circuit. You can see here that they've got very high peak pressures because they are, but the plateau pressures are still less than 30, but they're being ventilated pretty hard. In other words, they're on the anaconda circuit, and that means they get inhalational anesthetics to try and help them out with the isoflurane. And we're also trying nitric oxide at the same time. So they're really sick. But we were kind of winning for the first few days. Now, these pictures are not pretty, but it gives you the idea, I think, of what we're going on. Maybe this is a bit hard. Can I persuade? It's not that easy actually to tell this. I mean, it's a bit unfair. Just tell me what you think, because these patients are really hard to scan, right? So I can only get subcostal pictures.
Yeah. So it's a subcostal view of this patient. I can see so this echo was on day 1 or 2, is it?
Yeah, day 1. So it's Monday morning. She's just come in. Their FiO2's okay. Their oxygenation's okay. The CO2's pretty high, not unexpectedly. Chest X-ray looks okay, but normal renal function. Yeah.
So obviously this patient is very hypoxic, tachycardic, and CO2 is very high, and the pH, I presume, is going to be low, and all of these factors is causing this dilated right ventricle, I can see. There is a good, I guess, radial contractility of the right ventricle, postal views. And on the right atrial side, septum might be deviated onto the left side, I guess. But it's very hard to know.
Yeah, I think I'm giving a terrible picture, aren't I? Maybe I'll just use this as an example of talking about the, from a subcostal window, I've got a pretty dodgy 4-chamber here. But if you rotate, I don't know whether everyone does this, but if you rotate the probe 90 degrees and look to the patient's left, you can actually get short axis view, which was really important for this patient, because I think it shows that the right ventricle is not massive and the interventricular septum is not pushed over. Because this was really important to me, because on Thursday, the wheels fell off. And I came in on Thursday morning and they talked about the oxygen requirements going up, the lung volumes going down. There's worsening gas trapping. Suddenly we've got gas trapping. She was on 0 PEEP, gas trapping of like 10 centimeters of water, acute kidney injury. And it looks like there might be some basal atelectasis going on. So now she's suddenly on an FiO2 of 1, fever and sputum's now starting to come up, developing potentially hospital-acquired pneumonia with those X-ray changes. Oxygenation's much worse, and she's got a worse pH, and now she's got acute renal failure as well. So what does that all tell you? I think I might be able to actually show them next door to each other here.
So that's a good comparison, I guess.
Try that.
And on the right side, where I guess it is the apical 4-chamber or subcostal, I'm not sure, but whatever the view is, the right ventricle is very much dilated as compared to the previous one. Definitely the longitudinal contractility is much worse onto the left side, onto the right side.
Yeah.
And in the interarterial septum also is deviated to the left side, onto the right side of the follow-up echo, I think. And on the short axis view, there is a D-shaped septum, definite enlargement of the right ventricle on the subsequent echo.
Really nice. So again, I'm probably repeating myself to this audience, but you know, obviously we've got acidosis, we've got acute kidney injury, we've got a reason why the pulmonary vascular resistance might be changed, and that should, all of that should prompt you to think about the right ventricle when someone's on a lot of ventilatory support, because with the support that we were giving her, we blew out her right ventricle. And I think it's a really tricky situation because ventilating asthmatics is, I think, pretty scary, and it's really hard to try and reduce pressures inside the chest. But it just means, I guess, she ended up doing okay, and she got extubated, and I do hope she gave up smoking because she got out of ICU. But, you know, I think smoking and asthma is obviously a pretty bad combo, especially if you're starting to get pneumonias on top of it on day 3 or 4. But with the right ventricle down, obviously, we made sure that we were trying to avoid acidosis. We thought about dialysis. I don't think we had to do it. We avoided fluid overload. We made sure we dried her out pretty aggressively and treating the infection as fast as you can and trying to improve her pulmonary hemodynamics. Very nice, Sid.
Did you call that a McConnell?
No, so I don't hear the question. The question was, would I call it a McConnell's? I think the lung image, the ultrasound images are a bit dodgy for a start.
Not enough,
but I think she didn't have a PE. I think it was just the pneumonia that was going. Because again, I think this base of the heart still, I think we still got movement. I can't see regional wall motion abnormalities there, so I don't think so. But again, I think it's a great thought because we didn't scan her and I didn't anticoagulate her. And I think in these patients, if you did see a McConnell sign and you were worried about it, because it wasn't a deterioration suddenly, but you're right, these would be the kind of people we want to anticoagulate on spec, right, if you think it's there. Good question. Okay, hypovolemia. Sorry, before I do that, let's just, have we got time to quickly, let me quickly, before we go into the hypovolemia case, I might just quickly just go through the rest of it. So I guess that's, the last slides have been my simplistic way of thinking about it, where I don't really talk about inspiration and expiration. I just talk about the increased pressures inside the chest. I think that first half of this talk is the clinically relevant part. That's the stuff that I find much easier to explain and understand, and forgive me if I haven't done a great job of doing that today, but I find that one's the stuff that makes sense to me because it's of relevance when it comes to mechanical ventilatory weaning. It's of relevance when we are looking at the right heart. When it comes to inspiration versus expiration, I think the main things it's of use to is in assessment of fluid responsiveness and assessment of tamponade. In regard to its assessment in tamponade, I know that respiratory variation is exaggerated, and I'll show you the reasons why. It's just, I don't think I've ever not drained someone's effusion because they didn't have respiratory variation or something. I just don't find it's clinically relevant as the other ones. And in terms of looking for a patient who is fluid responsiveness, again, I find doing fluid responsiveness really challenging for some reasons that I'll explain at the end. And it's not something that I do enough of probably, because I think it takes a lot of time, it is fiddly, and it often doesn't particularly change my clinical judgment, I'll be honest. But I'm really open for discussions on that. And I admit that I do not know this stuff well enough and still have to learn it before I try and talk about it. So yeah, open for criticism on that. Thanks to Andrew Hilton for letting me steal these amazing slides. You do such a great job, so I do appreciate it. Thank you. Okay, so here's the cardiorespiratory model. Okay, we are going to cause changes in the lung volume with inspiration and expiration. Those changes in lung volume are going to change the intrathoracic pressures. All right, we are going to have part of the hemodynamics that are in serial interdependence, as in if we change pressures in one chamber, it will cause flow to another. But we also have parallel interdependence, as in right ventricle to left ventricle. And if I dilate up the right ventricle, I squish the left ventricle. Okay, so let's start with spontaneous ventilation. And we are at end expiration. I have my mean systemic filling pressure or pressure in the IVC. Some people don't believe in mean systemic filling pressure. Call it whatever you like. We have a pressure in the abdominal venous system. We have pressures in the right atrium, we have pressures in the right ventricle. That leads up into the pulmonary hemodynamics, which returns blood through the pulmonary venous circulation into the left atrium, into the left ventricle. All right. Flow obviously goes from a higher pressure to a lower pressure, and that's how we get blood going round and round. And then it gets moved into the pulmonary venous system and the left atrium. So if the left atrium pressure rises, obviously you're going to reduce flow into your pulmonary venous system. Okay, so normally the pressure in the IVC, or the mean systemic filling pressure, is minus the right atrial pressure, gives you your venous return to your systemic, to your heart. The venous return to your pulmonary system is going to be your pulmonary vasculature pressure minus, your venous return from your pulmonary system is going to be the pressure in your pulmonary vein minus the left atrial pressure. And again, you've got to have, that's got to be higher than that to cause flow. You've got a pericardium that allows movement of the chambers, because normally it's not got a lot of pressure in it, because the intrapericardial pressure is approximately equal to your intrathoracic pressure. And obviously that is not going to be the case when we start talking about tamponade. Okay, where'd I go? All right, so let's take a breath in. So as I take a breath in, I am going to reduce my intrathoracic pressure. That is going to cause my right atrial pressure to reduce. That is going to cause the pressure difference between my mean systemic filling pressure and my right atrial pressure to go up. So therefore, I increase flow towards the heart. Okay, that can cause the dilation of the right atrium and right ventricle circle. But more or less, we get an increase in the right ventricle preload, which will increase your right heart volume, as I just said. With the inspiration, I guess depending on what your underlying physiology is, it will do different things to your pulmonary afterload. For example, if you can improve oxygenation or you open up airways, that can reduce pulmonary vasculature. If you're overexpanding it from something like, I don't know, increased inspiratory effort against a closed glottis or COPD and massive inspiratory efforts, it's going to do different things. So let's say you do reduce your pulmonary vascular resistance, that can cause the volumes to then cause your septum to shift, and that can affect your left ventricle. But that's not all the time, all right? So you can either increase or decrease your venous return to your pulmonary system. Most often we tend to decrease the preload to the left heart because you get pooling in your pulmonary vasculature, okay? Because you're decreasing the pressure so things can sort of pool in there. All right, so if you reduce your flows into your left ventricle, we then will reduce our output from there, okay? So decreased LV preload, we reduce the LV volume, decrease the compliance, and that can reduce the output. As well as that, we can also increase the LV afterload because of that pressure difference between the inside the heart and the outside the heart. If we breathe in and we reduce the pressure, that will pull the intrathoracic pressure down, because again, LV afterload is pressure in the LV minus the pressure in the intrathoracic space. If we make it more negative, that can cause, that's going to increase that afterload, which is the pressure difference, right? Everyone with me so far? We cool? Send me a message if I'm not making sense. So here's an example that I saw in a patient that made me think about this. This is a patient who did not have a lot of respiratory issues, but we can see these huge swings whenever they breathe in or out. And here during inspiration, you can see the septum being pushed over. And this is someone with, I think it was asthma, could have been COPD, who's having some big inspiratory efforts, actually doing spontaneous ventilation on a ventilator. So septal shift with inspiration. So what's the normal respiratory variation? So as we inspire, we see a reduction here in the E and A ratio through the left ventricle because of reduced LV preload and increased LV afterload. and that will cause a small drop in your blood pressure. All right, that is normal. That's probably happening with us as we're sitting here. This may be an indication of fluid responsiveness if you've got a respiratory variation that's greater than 15% or whatever value you want to talk about, 15, 20%. And that's on at least sort of 8 mils per kilogram tidal volume when we get onto that. What it's worth. Okay, tamponade. So tamponade is obviously associated with hypotension, pulsus paradoxus, raised CVP, tachycardia, and a low cardiac output. And that's because if we've got decreased resistance through our pericardial sac, we are going to restrain the RV free wall from expanding. That means that the pressure changes are going to be exaggerated in the heart chambers. All right. So we're more likely to get a leftward shift. So as you breathe in spontaneously, we are going to increase the volume in an enclosed space. Hence, we'll increase the right side of the heart, which will cause leftward shift. We are going to be decreasing our intrathoracic pressures with increased lung volumes, and so that may increase the return, therefore, of blood to the left atrium if we can, because we will have potentially increased up our venous return through the pulmonary system, because you got more blood in the right heart, hopefully overcoming the pulmonary vascular resistance, increasing blood flow to the left heart, and any changes will potentially be exaggerated. So let's try it on this one. So venous return, if you're in enclosed space, that will squash down, that will prevent movement from going. So you'll increase the pressures in your right atrium, and that might increase pressures out of the heart depending on your pulmonary vascular resistance. That's going to cause a shift over to the left in the heart. Depending on what's happening with the RV afterload, we may have an increase in the pulmonary vascular resistance. That's going to maybe increase or decrease the venous return as we were discussing. But if we've got that shift over there, that will decrease the left ventricle compliance, and that can lead to the decrease in volumes leaving the heart. All right. So that's why we'd see more variation in the right side of the heart. And I typically have maybe 40 to 60% variation with respiration in the right side of the heart across the tricuspid valve, and maybe a little bit less on the left side of the heart, because the right side of the heart should be more compliant. So here's a really nice example. Again, this is all from Andrew. So he's showing beautiful respiratory variation through the left ventricle with the respiratory phase stuff going on up here with a huge pericardial effusion. Right ventricle free wall collapse, right atrial free wall collapse. And I think we're seeing the left atrium might even be going there as well. Big variation with spontaneous breathing. As we start to drain it, you see that variation has changed markedly. All right, so with the effusion drained, the respiratory variation is obliterated because we're allowed a more compliant pericardium. All right, last thing, and then I'll stop talking. Inspiratory positive pressure ventilation. So during expiration, so we start with inspiration, So insufflation, we might call that. We are going to increase up the pressure in the chest. That's going to increase up the pressure in the right atrium. That is going to make that pressure difference between those two less, which means you're going to reduce RA preload. We are going to increase the pressure inside the chest, so that will squish the pulmonary vasculature, so it will increase the RV afterload. So that's we're going to reduce the flow out of there, and that in turn can either increase or decrease the return to the left side of the heart. And again, it depends on the RV response about what we're going to do to our diastolic function or our preload on the left ventricle. And as we discussed, we're going to decrease our afterload because it is the difference between pressures inside the heart and pressures in the intrapericardial in the pleural space. So we will have reduced it like that. So what does that look like? So here we can see with inspiration, we can see a rise in the blood pressure with inspiration. All right. So finally, let's talk about fluid assessment. So does anyone use this for fluid assessment, the passive leg raising, respiratory variation? Can you give me an indication of how you use it? And I'll tell you how I do it. If you saw a pattern like this in a mechanically ventilated patient, what are your thought processes? So people often see these kind of swings in the art line or things like this and say this patient needs fluid. What do you think about that?
Well, first I would point out that fluid responsiveness is not necessarily an indication for fluid, and that variations in cardiac output are normal with respiration.
Beautiful. So not everyone needs fluid just because they are fluid responsive. Just like us sitting here, we don't need fluid because we're not in shock. So you've got to be in shock. So. Nice. So you've got to be looking to increase the cardiac output for some reason.
Yeah.
Nice. Yeah.
And that cool. And that it depends on the clinical cause of shock, and that if it's an issue with the mean-systemic filling pressure, then improving the stress volume with vasopressors might be more appropriate.
Nice. Absolutely right. So particularly something like noradrenaline, that's going to cause some venoconstriction and therefore increase up your mean systemic filling pressure. Yeah. Beautiful.
And then, and so if I decided to formally look for fluid responsiveness, I would make sure, so this is looking at stroke volume variation over time.
Yeah.
So I would make sure that the caveats were in place and the patient was in sinus rhythm and that they were deeply sedated or paralyzed.
Nice, because you can't have any kind of spontaneous breathing effort because that will mean you've got variations in the intrapleural pressure. Beautiful.
And then 8 mils per kilo of tidal volume or greater.
Yeah, so transiently increase up their breathing. Yep.
Yeah, and then
for the tidal volume, excuse me.
And then I would look for 15% variation.
Nice. Beautiful. So yeah, I did exactly the same way when I'm doing it, and I probably don't do it enough. Anything else about, there's another reason why I don't do it a lot, and that's because I find that it's tricky. So on this view here, this is someone who actually doesn't have any respiratory variation. What this person does have, though, is the person who's doing the scan having an unsteady hand. So if you look here, we've got a closing click. We lose the closing click when that patient starts to breathe. You've got a three-dimensional structure, which we're assuming you're right down the gun barrel of. As that patient breathes, that gun barrel can move. And that's why you've got to be really careful with how you're scanning people. And that's one of my theories, is that I think it's really easy to make mistakes. So the interrogation is key. So understanding what the Doppler trace is telling you is really important, I think, because this closing click is lost, which tells me that we're starting to slip out of the ideal area where we want to be. A potential way that it might help, I think, rather than looking at that respiratory variation, is using exactly what Lewis was saying with that 15 or even use 20% change, but I just do it on an LVOT VTI. You've got to do it at the same time of the respiratory cycle. So I classically do it at end expiration. I don't think it really matters where the hell you do it, as long as you're doing it the same place in every, when they're down and up. And what I mean by that is I start off by doing it when they're sitting upright. So 30 degree at least head up. And I put my hand on the chest, I take a picture, I try and get it with my closing click as accurately as possible and measure out the LVOT VTI. Our beds are not super easy sometimes to do a passive leg raising maneuver, but I find if you lay the back of the bed down and then you sort of tilt the whole bed up, so in actually sort of using the the tilt function of the bed the wrong way, you can make it so that you're mobilizing that blood well. And then I make sure I'm, again, at the same time in the respiratory cycle, make sure I'm seeing a closing click, try to measure it again. And I look for a 15 or 20% rise in the vasculature, in the LVOT VTI. And that will help tell me if they are fluid responsive or not. I then flip them back up and make sure that I measure it again, just to check that my measurements have been correct. When you put them then back head up, make sure the LVOT VTI goes back to where it was. So I guess that's my tip and trick for dealing with that.
That was a published method by Pinsky.
Yes, absolutely. That is a well-published method, well described by the French cohort, and relatively well described. All right, guys, I'll probably stop talking. Let's just do a case if we've got a few minutes. So just in conclusion, I think heart-lung interactions are important to know about for all the reasons we discussed, from weaning, RV dysfunction, trying to optimize the PEEP, assessing for fluid responsiveness, and in tamponade physiology. So we love talking about it in the exam because it's really hard to describe, as I've probably demonstrated this afternoon. So how about we just try and do a quick case? Who would like a go at this? Sam or Kylie, do you want to have a go? You don't have to.
I don't mind, but are you guys supposed to be practicing for the exam?
I think the people who we've smashed, well, maybe you're right. Actually, thank you, Kylie. That's really kind of you. Lewis is doing his exam soon. You're absolutely right. I should absolutely hammer him. Good call. Excellent.
Thanks, Kylie.
Excellent. Come a bit closer just so everyone can hear you. Okay, so this gentleman is 78 years old. He has failed extubation after a short run of relatively mild pneumonia. He got over the pneumonia, then he failed extubation. His past medical history includes ischemic heart disease, and the request came through for an echo of query cardiac cause of failed extubation. I am not the clinician who did any of this, so we can bag them out. Again, images are not perfect, but demonstrating is quite nice.
Yeah, so I guess straight away I can say that there's probably a cardiac cause or cardiac contribution to the failed extubation. There is LV systolic dysfunction with moderately impaired ejection fraction. There's the E-point septal separation is increased, and it looks like the mitral valve may be a little bit restricted in the posterior leaflet. I'd like to put colour on that. Left atrium looks large. The right ventricle outflow tract, the free wall there looks like it's moving okay. Posteriorly, it looks like there's some B lines in the left lung. Make me think about interstitial syndrome.
Nice. One of the things also about the mitral valve, just in passing as well, so the mitral valve prevents regurgitation because you've often got a significant coaptation point. I'll try and do the dance again. So when the mitral valve closes, it's not just a perfect union. It's actually working because it has redundancy in the leaflets that mean that when they close, you have an overlap. So, and when you have an overlap and then the pressure increases, you get a nice closure.
Yeah.
As you start to get dilation and this coaptation reduces, when you're starting to just see the little, it looks like these things are just closing like that. That makes me think as well about mitral regurg.
Yeah.
And I think if we're seeing that as well, I think we've got to be concerned about raised left atrial pressures. So talking about the restricted things as well, but don't forget about the tips, the coaptation.
I should say the LV size looks like it's increased too.
Yeah, LV size looks big. That's why I think we've got this bad coaptation. And I reckon we've got significantly raised left atrial pressures because I'm reckoning this mitral regurg, even with the color here, it's pretty dodgy color, but yeah. I reckon it's going to underestimate how bad the mitral regurg could be because we got raised left atrial pressures. So I think if we know someone's failed extubation, we've called it a cardiac cause. I think it's important to start talking about the left atrial pressure. So again, that's where the stem is leading you.
Yeah.
You know, if you failed extubation, you fail extubation because of pulmonary edema, right? In an echo exam.
Yeah.
That's left atrial pressure. So if someone's giving you that stem, you do that next thing about taking that examiner to going to where you know the examiner's going. And I've got to be going where left atrial pressure is.
I'd like to see the diastology then.
Nice, fantastic.
So if I can see the M mode for the mitral valve first.
I don't have that.
Oh, sorry.
Bloody sonographers.
Looking for a V bump,
Nice. Oh, cool. All right.
which looks like it might be present.
Might be present in there. So the B bump suggestive of at least moderate diastolic dysfunction.
And then the mitral valve inflows. So that's a big E, little a.
Big E, little a. E value is 1.
Yep.
And then I've got my medial TDI, my medial E prime. It's probably that one there, isn't it?
Mm-hmm.
Is probably about
Yep.
4. Oh, here, I've got to measure here. So it's 0.03.
Yep.
And then the lateral is 0.06. So that makes the E to E prime 20.
20. Okay.
20 and above.
All right. So so looking at those mitral inflows and the mitral tissue Doppler velocities, that looks like there's probably some diastolic dysfunction with pseudo-normalization, and I would say that mitral tissue velocity inflows greater than 15 is associated with high left atrial pressure, and is probably, and also a wedge of 20 or so, and so that would probably explain a cardiac contribution to failed extubation.
Very nice, very nice. So with the diastolic dysfunction, again, the bit I really liked about the new guidelines is they talk about the gradings just like you've said, but they, more importantly, I think that they estimate that the gradings are almost as important, talking about the raised left atrial pressure.
Yeah.
So in those guidelines, I think if you're saying moderate diastolic dysfunction, every moderate diastolic dysfunction comes along with raised left atrial pressure.
Yeah. So grade 1's normal left atrial pressure,
You got
grade 2's elevated, grade 3's
Nice.
elevated.
That's boring. Just in passing, what's that?
That's the delta pressure over delta time of the mitral regurg, which is, and I can never remember the normal values. I think
So greater than 1200 is normal, less than 800 is severely abnormal.
Okay, so that's intermediate.
Yeah.
Yep.
Because what does it represent?
So it represents essentially the change in time over change of pressure. So it's a relatively direct measure of LV contractile function.
Very good. So it's LV contractile function. Nice way they've done it. Probably the mitral regurg jet isn't quite enough to do it. But just for those of you who haven't done it before, when you're measuring it, you've got to make sure that the sweep speed is super fast like this, like 200 millimeters per second, so that you can make this measurement. And I measure it by staying at -1 over here, and it's the pressure difference starting from there. I just put the cursor just on the mitral regurg, and I make sure it's at the -1 mark. You go from there, and then it's the change in pressure to -3. And so that means that you have a 32 millimeter of pressure difference over time. And then that dP dt can give you this value of millimeters of mercury change per second. And that's what the measure that they use in a cath when they're actually doing invasive measures of systolic function. And this is the way that we cheat doing it in, on echo. But it's worth, if you're going to measure it, you can't do it with 5 cardiac cycles on the screen. You've got to make sure you've just got 1, what you're interested in filling the screen.
I guess the other thing that if I was interested in left atrial pressure with an MR trace, although it's usually easier if it's central rather than eccentric, is getting the Vmax and doing a simplified Bernoulli equation on that. so 4V squared of the Vmax, and minusing that from the systolic blood pressure gives
Very
the
nice.
LAP.
Very nice. Very nice. What a great comment. All right, and I'd just say the last thing is if you're talking about left atrial pressure and they say, do you want any more images? I think calling for lung ultrasound would be fantastic, because what do you think of these pictures?
So this, so the right lung here, from apex to base, demonstrates a interstitial syndrome with more than 3 B lines per sector present in the entire lung,
Beautiful.
including the base. I can't see a pleural effusion, but it looks like there might be a small one.
But more importantly, we've got lots and lots of lung. So what does that tell you?
Well, so an interstitial syndrome means that there's fluid in the interstitium. In the context of that echo, I would look to see if it's symmetrical in both lungs. But if it was, in the context of that echo, that would be consistent with pulmonary edema.
Very nice. So there's the left base. Not the best echo images, because he did have a pneumonia, remember? Yeah, the left is not quite as impressive. And again, I think the person who's done this, I don't think it was me, but then just they're using the echo probe. They haven't changed the presets. It looks like, I think if you're going to be doing lung ultrasounds, you've got to use the preset function, because it's all about artifact suppression, right? So you can see the artifacts a bit better. Anyway. Are there any questions? Does anyone have any questions or comments? As I said, I'm sorry, probably didn't explain some of that brilliantly. I thought you did great with your.
Was that a pass?
Great with yours, certainly. Anyway, I hope that was useful. Are there any questions or comments from anyone?
Just say that left lung mid ultrasound shot you had at the end there, like there was consolidation. So I guess that's where his pneumonia was.
Yeah, nice. Yeah, very good.
Sam, can I just cross-check that I'm on the right page here?
Nice.
And really dumb it down. Is it that when you are spontaneously breathing, it's easier to get fluid into the heart, but harder to get it out of the heart? And then when you put the patient on positive pressure ventilation, either intubation or NIV, basically makes it a little bit harder to get blood into the heart, particularly the right, but easier to get it out of the left. Is that how I start to think about it?
Yeah, I think that's awesome. I like that.
Yeah, I like that.
Yeah, it's easier to get it out, harder to get it in when you're ventilated. And then say the first one again. So when you're breathing spontaneously, when you breathe in, it's easier to get it in and harder to get it out.
Yes.
Beautiful. Love it. Fantastic. Yes.
It's because every time you breathe in, when you're breathing spontaneously, you're sucking blood into your right heart. If it's going to the right heart, it's got to go into the left, right?
Unless you're getting pooling in your pulmonary vasculature. So you can, it depends on your pulmonary vasculature.
Yeah.
I'd have thought that just sort of, pulling the pulmonary vascular reinforces the change more than anything.
Yeah, nice. Thanks, Kylie. I agree with that.
Yeah, it's a good. I think it's worth mentioning that pericardial restraint is a normal function of the pericardium, and that particularly in heavy exercise, it functions to stop the RV from dilating out too much beyond its Frank-Starling mechanism.
Nice.
And that's sort of exaggerated in Tamanat.
Nice. Yeah. All right. Thank you very much, guys. I better get going. Thank you very much for your time, and we'll see you next week. And I hope we'll find time. We missed Benny last week. I do apologize. We couldn't make that happen at the last minute, but we will hopefully get her back up. She's got a great talk about prosthetic heart valves, which should be really great, I think, for the guys in the BDU. Take care, guys. See you next week. Bye.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.